Hi everyone, I'm Dr. Fernando and welcome to my surgical room today. So we're doing this gentleman's frontal hairline and doing a restoration of that. Slightly interesting case in that this patient's got these wonderful flowy cowlicks where it flows forward here and then as it comes around the side it sharply angles across and then backwards on itself. So a lot of the challenge for today's case is going to be creating that artistic flair to the hairline, but doing it in a natural looking way. So we're at the incision phase. We're just coming to the end of that. And if you come in close, David, you can actually see the large majority of the incisions being made. If I kind of use this swab to kind of demonstrate the direction and the angle. So this here is the angle of the hair in this corner here. As it comes into the sideburn, it's very shallow and down towards the ears to keep that natural and flowing. And then here you can see the angle just slightly changes. And this is the patient's natural hair direction. And then as it comes to the forelock, it does a very sharp twist across.
Gosh, that is a change of direction, isn't it?
It's a very sudden change of direction.
So you're having to follow all of this because it's such a strong...
So it's such a strong, and actually from the central elements, it's actually backwards.
Right.
So all of this then flows so strongly back on itself and then backwards and then flows across over to the right-hand side and into the right corner. So these are the kind of, some patients do have these very strong flows to their hairline and to the rest of their crown and spiral and the back of the head as well. But when we're recreating the hairline, we really must observe those natural flows for the most natural looking results. And you'll see that when we're doing these incisions, we're not just following the flows, but we're ensuring that we prioritize the right hairs to the right area. So coming back to the scalp here, David, you can see that we've done what we call coronal incisions. So these are incisions which use an angle blade. It's been a very artistic morning. Normally these incisions can take me 20 minutes. Today's one has taken me 45 minutes, nearly an hour, because it's more about the artistic flow of the hair today. All right. Great. Do you have any questions for me?
Yeah, I was just saying, when you create these incisions, obviously it's a far more challenging and artistic design to the hairline when they have this change of direction and flow. And you've dyed the scalp.
Yes, so this is methyl in blue dye. Yeah,
just talk us through.
It's really simple stuff. It's methyl in blue dye, and it's quite nice. It's almost a bit like when you're a kid and you kind of you rub that. I think it was like when you kind of rub it into like slits in a piece of paper or something. And the idea is that the dye gets taken up by the holes that you've created, and the skin itself doesn't actually take it up. So when we just rub a bit of dye on, give it a good spray and a clean, it really does illuminate those holes. It illuminates the difference between the coronal incisions, the sagittal incisions, so we know exactly where our grafts are going later on. This is particularly important, again, to minimize things like shot loss and minimize damage to native hairs. You can see that I'm using super high magnification. I can see all of my hair follicles that are native to the scalp, and I can see my incisions really clearly, and I'm making sure there's really good, healthy space between the native hairs and my incisions to protect those existing hairs as well. So a hair transplant on its own is not going to stand up and create, you know, a dense result. But when married together with the native hair, it can create a really beautiful, full and dense result. So protecting your native hairs with good magnification and careful incision placement is incredibly important in that regard. And then when it comes to the implantation, that dye just allows us to see those spacings and those gaps a lot better. Okay,
and you started with the incisions first of all.
Yep.
Is there
that's our little kind of one of our in-house methodologies that we've developed over the years. The reason for doing the incisions at this stage is a lot of our patients talk about how our graft numbers are always like slightly lower than what other people say. Well, actually, the way we do it is when we do these incisions, we count each and every incision that we've made. So we've designed the hairline, we've packed out the area, we've densified, and we've counted each and every hole. So we now know exactly how many grafts we need to go and get from the back to be able to fill up that area. So that's one of the benefits. So we're using exactly the amount of grafts needed. We're preserving donor area by not taking too many. And the other thing is time preservation at this stage, because when we do the incisions now, when it comes to the extraction phase, we can get those hairs out, put them back in without any delay. Yeah, absolutely. So this is the hybrid approach that we tend to utilize here at the clinic. As you can see here, I'm using an implanter pen. This is what some people may know as, or may attribute to sort of a technique called DHI. DHI constitutes where the graft is loaded into the implanter pen. You can see the technicians doing that here for me. And in DHI, the needle is sharp and it can break the skin and deposit the graft into the scalp. Now we find that actually with the dull implanter, so not quite having a sharp needle, but a dull needle, we're allowed to utilize our pre-made incisions that we did in the morning. And actually what's quite nice about that as well is because it's dull, it kind of follows the channel of those incisions in a really nice, natural way.
And you were saying earlier on about the patient had an existing density of around about 30% or 30 grafts.
Yeah.
And you're adding around about 30 to 35?
Yeah, if we can push maybe in some areas, and if the density allows and the blood flow allows, maybe to 40. Mm-hmm. But the idea being is that in certain zones, there is some native hair there. Mm-hmm. We've had a really nice discussion, myself and the patient, to understand that we can utilize that existing hair density, marry it together with the density that we're creating from the transplant, and that can even push us up to around about 70 grafts per square centimetre. Now, we've done a donor analysis at the back as part of my planning for surgery, and the patient's native hair density is 100 to 120 grafts per square centimetre. So it's not going to be full hair density, and that's all part of doing the right counselling and having the right consultation with the patient, that you'll never get full density with a hair transplant. But a hair transplant is creating that illusion of hair density. But when you can utilise the transplant plus the native hair density, that illusion can be that particular bit better.
Yeah, of course, exactly. And that's why sometimes it's often key to have a transplant. It's helpful if you've still got existing hair, because that can help then increase the density. But I think I did a video actually about how if you get over 50%, then often you can beat that illusion. So, you're talking about the patient might be 100 grafts per centimetre square. So
yeah.
if you can get over sort of 50, then that illusion can be very effective.
Oh, absolutely.
Depending on hair characteristics can help as well.
Well, absolutely. And then also factoring in that it's likely that in the areas of thinning that they've and miniaturization, they may still have densities of 100 grafts per square centimetre, but albeit miniaturized hairs. So when you're actually taking, say, 50 grafts per square centimetre, but the calibre of those hairs are actually the strong calibre that they have in the DHT resistant zones in the donor area, and you transplant that into the recipient zones. The lower density but high calibre combine to form a visual density which is actually quite similar to that of a uniformly miniaturised high density zone. Yeah. If that makes sense.
It makes complete sense, because patients often say, what density do I have here of their existing hair? There's often, it's as you say, you don't always lose numbers, you lose volume of hair. So you may still have sort of 60, 70 density, but you've just got lots of single hairs now.
Exactly that. And I think that's really all part of the planning for surgery, part of the consultation process. I think, when you go to any kind of clinics where it's a salesman doing a sales pitch, you wouldn't have these kind of candid conversations about those elements of surgery. Whereas actually, if you're having your consultation, with someone that really understands the transplant journey, a really well-educated patient advisor or a doctor, then ultimately you can have these candid conversations. You can have these thorough assessments, and it all goes to making sure that your expectations are suitably managed, because once you've managed those expectations, then you can go and flourish and beat those expectations. It's all part of the journey, and today's not been the easiest surgery. There's been challenges in terms of the extraction. There's been the directional differences and variations that we're seeing, and even here and now today there's a little bit of oozing, a little bit of popping, and it is really just ensuring that you have the right mental approach. You dig your heels in and endeavour for what is the best quality outcome, getting the grafts in within good time. So, we've got a stop clock on the grafts over there. So the first dish came out at 12:45 from the scalp, and that's pretty much in now, and that's gone in by about 3:30. So we've got that in within less than 3 hours, and we would say that optimal is between 4 to 6 hours. So, all of these type of things, it means that the patient needs to absolutely wolf down their lunch, but or if they can eat at all, but things like that are all for the greater good of the transplant. Yeah. And just going through that as well, you can see there that we've got a lovely blend of singles for the day. So we've got 360 going into the hairline, about 580 doubles going in, and then thereafter 562 threes and fours. So for someone with this patient, which has slightly difficult extraction characteristics, to get that many threes and fours and doubles is great. And again, it's just taking that time, endeavoring for high quality grafts, and making sure that they go in good time. And like I said, usually we would have even more people on the scalp, but I think just in today's case, where the directions are slightly awkward and slightly difficult, it's easier just to have myself and Georgia as two people with full access to all the different angles and directions to make sure the hairs and grafts can go in a nice streamlined fashion.
What I've noticed from moving to room is that you can all coordinate together, and you're all talking to each other, and there's the ability to be able to help out either doctor.
No,
as well.
for
So
sure. Having the team are a well-oiled machine. The doctors, myself, Dr. Vara, Dr. Goring, and Dr. Pather, when we're all here, that's 4 surgeons servicing 2 surgical rooms. And with that, you do genuinely have an ability to maintain that surgeon level quality on the scalp at all times. As you said, if one room is finding this things particularly difficult, we can all muster up and help along in that side. If for whatever reason, the technicians need a break and keeping them fresh, they can go and have their breaks. And so having a large clinic with a really big team that knows how to plug and play into different situations, different scenarios between 2 different surgical rooms is probably one of the key successes to our clinic over the years.
I think so, and the fact that everyone is part of the team, you're not hiring in freelancers.
No, yeah, that's been a real. It
takes time, doesn't it?
It takes time.
Yeah,
it takes time. But I think we learned that through experience of we hired Amity, who is now our lead technician, and we took her in from a very green place in terms of her background, her skills and experience, and she really thrived in the role. And we realized just that actually, with time, care and consideration, you can really train people to be really high quality technicians and build a team around that. Whereas and that's really, as a clinic, we've just invested into our time and effort into things like that in the long run has really just allowed us to build a lovely team. And I don't think we've used freelancers in the past and people that turn up for a day and don't see them ever again kind of thing, and you find that the quality of the work that you do is just not quite the same. So, and you have your long days, you have your long days and you have your short days, but everyone knows what they need to do in each of the different situations. How has your experience in the clinic been, David? What have you?
I've been to a lot of clinics over the years.
Of course.
So, but I think I was just saying to Dr. Vara that I haven't seen the implanter pens for a lot of the clinics I've worked with. It's always been forceps.
Yeah.
So it's interesting seeing the 2 alongside one another. I can definitely see the benefits of using the pens from witnessing it. But obviously there is the nice ability to have that somebody who's in the team who's great at placing with forceps, because there is benefits, isn't there, for the hairline grafts, I think. But I was going to ask, because there's a lot of hype on the internet about DHI and FUE being a completely different type of procedure. So what? I should state the DHI implantation technique,
of course. Yeah.
But I think the misconception is that it's marketed as a superior, procedure,
and it absolutely is not in terms of that is just marketing gimmick. There are lots of patients. I think maybe even this gentleman here who asked, or certainly if not the patient that I had yesterday, who kind of came to me in the morning and said, "Oh, a clinic had told me about DHI. Is that I was thinking about that." And I said, "Oh no, that's actually." We use a similar technique by using those implanter pens, and they didn't realise that is all just marketing and branding kind of terms that are used by clinics to try and sell you something that is potentially that they try and sell you something that is superior to what is conventional hair transplant surgery. DHI is referring to, or is likely to refer to, the implantation technique where you use a sharp implanter to specifically implant a graft into the scalp at the same time
At the same time, isn't it?
as the same time as making the incision. Now, again, we're not doing that exactly because we've made pre-made incisions with a dull implanter. Do you see how the one next to this has just started to make its way out a little bit here?
Yeah,
And that needs to just be gardened back into there. And that is the phenomenon of popping, and you do get that when the hairs are struggling to go back in, and you have to just kind of either just grab them and pop them back into the dish to be re-implanted, or sometimes you can garden them back in. But it actually makes the surgery a bit more technically challenging.
Often there's a big misconception again as to what is unshaven FUE. Some people regard that as just shaving off the donor area. Some people regard that as not shaving the recipient area. Some people would call this obviously unshaven FUE, but you've shaved the recipient area and the donor area?
We've shaven both, yeah. We would call this a minimal shave.
Yes, exactly. But because he's wearing his hair, he's long, he's going to be able to cover that.
Yep.
And at what point will it be safe for him to brush his hair forward in order to cover the recipient area? We're
quite comfortable with our patients bringing it forward within around about 4 to 5 days.
Okay.
Depending on, obviously we feel like the grafts generally have taken and are well seated by about 4 to 5 days. So we'll generally ask for some progress shots of the scabs and looking to see how those have matured over time. If it looks like they're all well seated and they're in place, then we'll actually then utilize that information to say to the patient, yeah, we're happy for you at this stage to bring your hair forward. So usually about 4 or 5 days. The minimal shave is hugely beneficial from a cosmetic point of view in terms of the recovery and being able to disguise the signs of surgery. It is hugely beneficial. It can change, the visual signs of surgery being evident from a month after surgery to a week.
Yeah, a week. Yeah, exactly.
And for that reason, we find it to be very, very popular for our patients. What I would say is, yes, there's a lot of different nomenclature about, long hair preview, unshaven tiered shave, unshaven recipient. Ultimately, people try and get caught up in that kind of, in those discussions and debates. But ultimately, it comes down to the patient, and it comes down to what the patient wants, what their recovery needs are, how many sessions they're looking to have. And we found that we can, offer the large majority of all the shave options, and our patients like us for being able to offer all of those variations. However, ultimately in the consultation, we have to sit down with the patient, explore all of those elements, understand that there's limitations to minimal shave, there's a limitation to unshaven procedures. You can't do as many grafts, you maybe can't get as high densities. And it's about weighing those pros and those cons with the patient and understanding and creating a plan that's suitable for them.
What I like about the treatment rooms is that you do all the consultations yourself, both yourself and Dr. Vara. Every patient will meet you.
Yeah, sometimes our patients are a little bit shocked, when I say, hey, I'm the surgeon here at the clinic. They're like, oh, that's the first time this has happened. And they're expecting me there for about 2 to 3 minutes, but they have a nice, 40-minute chat with me right from the outset on a video call. But it's really nice. I've always learned, in the hospital that, when you steer a ship in the right direction right from the outset, then it's much easier to stay on course. But if you just deviate in the wrong direction from the outset, you can end up way off course. Yeah. And I think if you have the wrong thing said to the patient in an early stage, and it's hard to undo that or unmanage those expectations later on. So for Rosh and I and for the rest of the team, the doctor team, having that initial conversation with the patient and just going through those elements is really reassuring for the patient, but also we know as well that they've got a very firm footing upon which they're setting off on that hair transplant and hair loss journey. And I think that's really powerful to us. It's something that it's a tricky one to manage as a clinic, because I would say that's our USP, that we are able to offer doctor-led consultations right from the outset. And as the clinic's grown and as, we've all become more popular in as a clinic, trying to be able to stick to those values has been really challenging, and then training surgeons who deliver on those values and maintain those values also very difficult. But something that we're passionate about, it's something that we do, and it's something that so far our patients really appreciate about our service.
I think that's key in what you said, because often as a clinic gets busier, the temptation is to do more procedures and to start to cut corners in that respect, and that's what I've seen over the years. I've been involved in the industry for a very long time, so you see these clinics start off, they have a great reputation, they get some great growth, and then they start to cut corners.
Yeah, for sure.
And as soon as you do that, the reputation goes and you start producing some bad results. That's it. I think it's almost impossible to recover.
Well, you're absolutely spot on. And they say that it takes years to build a reputation, and then just a matter of minutes to destroy it. So I think that is really, really important, is that maintaining that quality, maintaining the service that we have, and that doctor-led approach that we have for our patients is incredibly important. And I think, again, just like on that analogy of just steering the ship in the right direction, just having that initial virtual consultation with your patient then translates into the consultation itself that we have in person. That's the surgical planning session, looking at the patient's concerns about their hair, what they want from the outcome from surgery. Are there particular areas that they're bothered about? And then again, having that conversation and then meeting them again on the morning of surgery, slowly but surely you've just nudged everything all in the right direction. And then the doctor being the one doing the surgery, all of those plans, all of those strategies then manifest into the surgical execution itself. So from start to finish, you're giving the patient the full confidence to know that their concerns are being addressed in the real time on the surgical day.
I also think there's a danger, as we mentioned before, is that if there is a non-medical person who's doing consultations, and I've done consultations for years, but often, sometimes opinions, as I'm sure every doctor has different opinions on the right approach for the patient. It depends on their expectations, depends on their goals and hair characteristics and so on, and use of medication, all these things. There's so many nuances in terms of the procedure itself that a patient can go away believing that this is the type of procedure that's right for them, the number of grafts, and then when they meet the surgeon, that plan is completely changed. And that sometimes happens on the morning of surgery, where they actually get to meet the surgeon. Yeah,
it may well do. And I think everything ultimately comes down to probability and risk and things like that. And I think if you've met a couple of times before, the chance of that happening on the morning is slim.
Yes,
but it does happen. Yeah. It is a really, really, really good point. And I think that's the other crucial element, right? Is that I always say to my patients, just to say that if we're not singing from the same hymn sheet, then we shouldn't even be going into surgery together in that regard as well. So being able to say no, if you feel like you can't, get onto that same page and get onto the same level of understanding of what your set expectations and outcomes are for surgery. And so in those scenarios, I think for the surgeon and for the patient, the best thing to do is to go, to wish each other really well. Good luck with your hair loss journey. But it might not be that I'm the surgeon for you, and to seek someone that can maybe share that same passion in what you're trying to achieve. And I think that is probably a hallmark of a good surgeon as well. And having that ability to say that things are not maybe right for.
Yeah, I think it's patient. Incredibly important to be able to spot that somebody's not on the same page as you. And I always recommend to patients to have consultations with the doctor, whether it's by video or in person. It's key to make sure that you are on the same page.
Yeah.
Because if I think one of the keys to a successful hair transplant is meeting patients' expectations.
Very much so, and I suppose that.
And setting the expectations correctly in the first place.
No, I entirely agree, and I suppose that segues nicely into the concern side that there are people doing hair transplants out there that are not doctors and that they don't take the patient's considerations into account. And we're talking about technician-based surgery and things like that, non-doctors doing the surgical steps, doing the surgical procedures, and not counselling and managing expectations of the patients. And as we kind of have said, ultimately those type of clinics will eventually have bad results, will eventually have patients that are dissatisfied, and will eventually damage their reputation. We see that happen. You've been around for longer than I have, David. You must have seen that.
Oh, I've seen it countless amounts of times, but and you hear it all from patients in terms of having their consultations as well. And I think it's great that you spend so much time with the patients in the consultations as well, because often I've heard that you're very, very busy, and so to be able to provide that time, often I've met the surgeon. He came in, spent about 5 minutes, glanced at my hair, gave me a number of grafts, and then passed me back to a non-medical person. So even often if you do see the surgeon in some clinics, it's very brief.
Yeah, no, it is, and it is sad to see that. I can understand, as you have seen us today, it's very challenging. It is. We are busy as a clinic. We're always kind of consulting. We're all virtually and in person, plus also operating day in, day out. Finding the time is difficult, and building that and growing that is difficult. I think for us, the way we've tried to navigate that problem is by getting a stronger team of surgeons, and so far that's working really, really well for us to be able to continue to offer that level of care to our patients. And I hope other clinics, follow suit in being able to deliver that. I also think patients are becoming a lot more well versed. The content that you're producing and similar stuff, educational pieces, to really give people a window into the surgical room and see what it entails. Gives patients or arms patients with a lot of insight into what they should be asking as questions and what they should be looking to see from their potential clinic.
I think it's great that there is so much content out there now for patients to see every aspect of the procedure, and what we're producing here today is going to give everyone an insight in terms of exactly what goes on. Just changing tacks a little bit in terms of is there a favourite part of the procedure that you have? I
personally, this is where I'll be copying Rosh, aren't I? For me, I do love the incisions, particularly the incisions like what we've done today, where it is purely like artistic, and understanding the different flows and designing the hairline, and then making sure that it's going to balance and create a beautiful hairline for the patient. I heard it somewhere in the ISHRS, but it really did ring true to how I feel about hair restoration surgery, is that when you're doing a hair transplant, you're not painting a picture, but you're actually creating a 3D sculpture. And I love that. I love the 3D element to a hair transplant, and understanding that how it frames the patient, not just from the front on, but from the side, the top, the bottom, and when designing that as part of the incisions and the flow and the naturalness and working into the existing native hair. I'm very passionate about the artistic sides to that. And I do like, and this is just me being a bit OCD, but I just like the implantation. It's a bit like Dr. Pimple Popper, where you have like a little spot that you need to pop and fix, and the implantation is fixing it. Is fixing all the little holes that we've created and just putting a lovely little hair in there. So those two key elements from the recipient side, I would say, are probably my most favourite parts of the surgery itself. And then, of course, I also love the rewarding nature of the surgery, the patient, their journey, them coming to you in a very, very vulnerable state, and having the ability to empower them with an option to fix it. And it is always just an option. They don't have to take it, but guiding them through that journey is also a very, very, very meaningful thing to be able to do.